I'm Jervoise Andreyev. I'm a gastroenterologist and I'm an honorary professor at Nottingham. For many years, I've been interested in side effects of cancer treatment and have an expert practice in trying to help people who are struggling following their cancer therapy. Surgery for bowel cancer has one real aim, and that is to cure you of your cancer. When a surgeon undertakes treatment, often in combination with other specialists to cure the cancer, there is a big cost to it, and a lot of people will run into problems. The first good news is that many people do not have problems after cancer treatment. And the second good news is that the cancer treatments that have been developed are getting better and better. But depending where your cancer is, so if you have a rectal cancer, up to half of all people afterwards will say that they have trouble with their bowels, while if the cancer is on the right side, 1 in 5 people will say they have long-term problems with their bowels. Traditionally, doctors have told patients that things will settle down if given long enough. But what seems to be quite clear now is that it will take a bit longer to settle to the level that it will go to than specialists often tell you. Our data suggests that the average patient takes somewhere between 6 months and 9 months for their bowel function to settle down to the level where it will be long term. If after 6 to 9 months, people are really still having issues which are stopping them doing things that they want to do on a regular basis, they really need to seek help, because the right intervention can make a huge difference to how the bowel function will work long term. Going often to the loo and having to go urgently is a very significant problem for lots and lots of people after colorectal cancer, and it's something that you should not tolerate, and it's very important that you ask for help for this from your specialist cancer team. There are lots and lots of different reasons why people might have to hurry to the loo or go very often, and the different causes for this require often quite different treatments. Sometimes the treatment you've had has changed the consistency of the stool. And then sometimes, if that is the case, simple use of antidiarrheal medication can help. Sometimes there are things in your diet which will make this a bigger problem. Having too little or too much fibre is a very common reason for urgency and frequency. Very commonly, after people have had surgery for bowel cancer, they can develop a condition called small bowel bacterial overgrowth, where they get their own germs growing in parts of the bowel where there shouldn't be germs. And that can cause frequency and urgency. And if that is the case, a week of treatment with the right antibiotic might make everything improve. Another condition called bile acid malabsorption, where people develop sensitivity to fat in their diet, is quite common after a variety of treatments for bowel cancer. Again, if this is diagnosed, proper treatment, either with changing diet or tablets, can be instituted. Lots of people after cancer treatment have more than one cause for their urgency and frequency. So they need a systematic diagnostic approach to sort out what is going on. So if this is a problem, speak to your cancer team. And if your cancer team are not sure what to do, then what you need is help from a gastroenterologist, a specialist who will deal with these sort of issues. Constipation can be quite a big problem for people after bowel cancer treatment. Some people will have always had constipation even before they had their bowel cancer treatment. And so whatever treatment you've had for your bowel cancer won't necessarily lead to a resolution of that issue. The most important and simplest treatment to try and help with constipation is to make sure that you sit correctly on the loo, that you don't strain. And to do this, what you need to do is to sit on a lavatory so that your knees are higher than your hips. So you need to sit in a position so that your knees, you have a little footstool under your knees, and then you lean forward. The bottom of the bowel goes through a bit of an S-bend, and if you sit with your knees higher than your hips, with your feet on a little stool and then lean forward, you straighten out that S-bend, and so that makes it much easier for things to come out, especially if the muscles in the pelvis are a little bit weak. The second thing which is very helpful to do are to do some pelvic floor exercises to strengthen the muscles which guard your bottom and push things out. For these exercises to work, they need to be done quite frequently. They only take about 2 minutes to do, but they need to be done 10 times a day. So one has to get into a real habit of doing them. You'll do it when you get up and you're sitting on the edge of the bed, first thing in the morning. You do it before breakfast. You do it after breakfast. You do it when you're sitting at traffic lights, waiting to go to work. You do it when you switch a computer on. You do it when you switch the computer off. You do it when you switch the telly on. You do it when you switch the telly off. Some people find it's quite useful to download an app to their phone to try and remind them to do pelvic floor exercises. Pelvic floor exercises can really make a very big difference with constipation, but they take about 4 weeks of doing them 10 times a day for that 2 minute each time for them to be beneficial. How to do some pelvic floor exercises will be loaded onto the Bowel Cancer UK website, and you can download some information how to do that. If pelvic floor exercises and changing your position on the lavatory hasn't sorted out your constipation, the next step is to consider stool softeners. And there are 2 which are particularly helpful if having fibre upsets you. Lots of people think that fibre is good for them, but too much fibre or too little fibre can both be quite troublesome. So if adjusting your dietary fibre doesn't make much difference, then there is a non-fermentable fibre called Normacol. It's the only one available on the market, and your GP could prescribe it for you. And some people find that Normacol can be very helpful when they're constipated. It has to be taken with plenty of fluid, and it doesn't tend to upset people in the same way that dietary fibre does, because it's not fermented, so it doesn't produce gas. The alternative might be to use some capsules. And in particular, there's a very useful stool softener called sodium docusate. And people will often find that somewhere between 2 and 5 capsules a day of sodium docusate can be very useful. I don't find that it's very helpful to use laxatives which are fermented and produce gas, because I think when people have had bowel cancer treatment, if they have a lot of gas, they often run into big problems with that gas because they don't know when it's safe to release it, or if they release it, sometimes they also get some leakage. So my own practice, I am very cautious about using laxatives like lactulose, fibre gel, and Movicol, which all very widely prescribed in other situations, but lots of people after bowel cancer treatment would find those three ones particularly unhelpful, while perhaps Normacol or sodium docusate would be better. Reversing a stoma which is created will be the optimal timing of reversing a stoma which is created as part of your initial treatment for bowel cancer will be discussed with you by your surgeon before your first operation. There are a few things that can be done to try and optimize bowel function after that stoma is reversed. The first thing is, for a few weeks before it's reversed, is to practice pelvic floor exercises. And there are some data to suggest that people who do that for 6 weeks before an operation find that they get better control of their bowel function quicker. Pelvic floor exercises need to be done 10 times a day. They only take 2 minutes to do. And some people find that downloading an app to their smartphone to help remind them to do them at regular periods through the day can be very useful. If you have a look at the Bowel Cancer UK website, you'll find where you can find pelvic floor exercises. Sometimes there needs to be a delay in reversing your stoma, so it doesn't compromise the treatment you have to make sure that cancer is treated optimally. But in principle, people should aim to have their stoma reversed as soon as is possible. The earlier it is reversed, the more likely they will have better function longer term. Once the stoma is reversed, if there are problems with continence, if there are problems with leakage, if there are problems with having to go to the lavatory too frequently, this is something that you should really challenge your cancer team about if they're not improving after a few weeks. And it may well be that you need specialist referral to a gastroenterologist to see if you've developed some reversible problems as a result of your surgery or other treatments you've had for your cancer. And it's really something that you mustn't put up with, and you have to bring to the attention of the doctors looking after you. Well, I'm really sorry to hear that you're struggling at this point. Almost certainly, without some sort of intervention, if you are having difficult bowel function at a year, it's going to remain at that level on an ongoing basis. Sometimes a stoma can be a very good option. And while technically operating on cancers very low in the pelvis has become better, and technically it's possible to remove cancers which in the past would always have led to a stoma, but now a stoma is not required, doesn't mean that the person who has that operation is going to end up with good bowel function. So a stoma should always be considered, and there are many people who have lived very full, happy and busy lives with a stoma long term. If further surgery and a stoma is not something that you would want to consider unless it was absolutely 100% essential. Then it's very important to see a gastroenterologist who's got expertise in managing difficult bowel function after cancer treatment, to see whether there are reversible causes for your ongoing symptoms. It's very common after radical surgery, often combined with chemotherapy and radiotherapy for other conditions, to intervene which make bowel function worse. Three very common conditions which are very treatable are the development of germs in places in the bowel where there shouldn't be germs, small bowel bacterial overgrowth or small intestinal bacterial overgrowth, where sometimes a week of treatment with the right antibiotic can make a huge difference to bowel function. A second very common issue, depending on the type of treatment you have had, is a development of sensitivity to fat in your diet, a condition called bile acid malabsorption. And again, there's a very specific scan which will diagnose this. And if you have this condition, changing your diet or tablets or both can make a very big difference. After some forms of surgery, for bowel cancer, some people run into problems with not producing enough juice from the pancreas gland to help digest your food. And if that is the case, then having some pancreatic supplements can transform bowel function. Other people are having too much fibre or not enough fibre, or drinking a little bit too much wine, which can sometimes upset bowel function, or doing things with other medication which could be rationalized to improve things. So a stoma is not inevitable. Sometimes people who I see in this situation, despite optimizing their medication and sorting out other treatable causes, we can't give them adequate bowel function. And then sometimes a stoma is a very good option. But if your bowel symptoms have not settled at a year, you need to see a specialist about that to see what can be done further about it. Low anterior resection syndrome, LARS, is a condition which happens after people have had their rectum resected. So essentially, the lower part of the bowel, the rectum, is like a big elastic bag, and it can expand to quite a large size to hold a lot of poo, and it can hold that poo for relatively long periods of time. When you have rectal cancer, the surgeon has to remove some or most of the rectum. And so the capacity of the bowel to hold a lot of stool for any prolonged period of time is hugely reduced. Because what essentially happens is the colon, which is quite a thin tube, comes down to this rectal capacitor, this elastic bag, and that stores the poo in it until it's time for someone to go to the loo. If that elastic bag is removed, then you've got the narrow tube coming down to the exit, and quite a little bit of stool will make people feel that they want to go to the lavatory. And so with LARS, low anterior resection syndrome, people will tend to go to the lavatory quite a lot. They will find that they tend to have their bowels open in clusters. So they might go 3, 4, 5, 6 times, all in a very short time, because they think they're finished, get up, and then feel they have to go again. They often have to rush. They often feel that they haven't emptied out properly, and they often struggle with controlling the bowels, so they get leakage. It's a very, very tiresome syndrome. It really interferes with people's lives. There are some simple interventions which sometimes make a difference. And if this is something you're struggling with, it is very, very important that you talk to your clinical team, to the nurses and doctors looking after you, to see what could be done to help you. So I think it's a bit shocking, really, because rectal cancer is very common. And low anterior resection syndrome has been documented as a side effect of rectal cancer treatment for decades. But there has been almost no research into how to treat this condition optimally. And the vast majority of people who struggle with LARS are told really they need to be grateful that they're cured of their cancer and stop complaining because nothing very much can be done. I believe that one should use a systematic approach to the treatment of this condition. So if people have got an element of diarrhea, one needs to exclude a number of other conditions to make sure they're not present in addition to LARS. So that would include things like bile acid malabsorption, small intestinal bacterial overgrowth, pancreatic insufficiency, all common issues which arise after a variety of cancer treatments. The second thing that is very helpful to do is to ask people to sit on the lavatory correctly. So to try and empty the lower bowel efficiently, what one really needs to do is have a little stool under one's feet so one's knees are higher than your hips, and then lean forward. And the bottom of the bowel goes through an S-bend, and by doing that, you straighten that out. And sometimes that makes it easier to empty the contents of the bowel without needing to strain. The third thing that will help some people with LARS are to do some pelvic floor exercises. These take some weeks to start to make a benefit. So if, like me, you give up with your pelvic floor exercises after a few days, then you won't get any benefit. But you can download from the Bowel Cancer UK website information about pelvic floor exercises, and there's something that needs to be done 10 times a day. They only take about 2 minutes to do each time, but you need to get into a real habit of doing it when you get up, before breakfast, after breakfast, on the way to work, when you get to work, and so on. The third thing that can sometimes help with LARS is bulking out the stool, to make the stool bigger so that when you go to the loo, you feel you've got a better clearance. People use a variety of different agents to do this, but I feel that one of the most helpful drugs is something called Normacol. Normacol is available on prescription from your GP. And Normacol is a completely unique product. It's a non-fermented fibre. All the fibre that we eat in our diet is fermented, so it produces gas. And gas is quite troublesome in the bowel after an operation. So having more fibre in your diet often won't help things. But some people find that Normacol helps bulk the stool up without producing gas, so that when people go to the lavatory, they feel they've cleared out best and some of that clustering goes away, that need to go lots and lots and lots of times. Sometimes using a tiny bit of an antidiarrheal, something like loperamide or Imodium, can be very helpful. In lots of people with bowel cancer, Imodium in the tablet form doesn't work very well because maybe one tablet's not enough, but 2 tablets constipate too much. Or people will have loperamide or Imodium tablet, and then they won't go for 2 or 3 days and then become uncomfortable and then tend to have a bit of an explosion. So if you're struggling with Imodium and the stool's a bit soft, but you do find that it can be a little bit helpful, there are 2 strategies which might make it better. One is to use the Imodium half an hour before a meal. On the packet, it says use 1 or 2 tablets when you've had diarrhea or whatever, but that's like bolting the door after the horse is gone. If you take Imodium or loperamide half an hour before a meal, what it does is it slows everything down afterwards. So if you're having a real struggle with your bowels first thing in the morning, often taking the loperamide half an hour before your evening meal will make the mornings much more tolerable. Other people find that a loperamide tablet is too much. It's very difficult to get the dose correct, in which case you can ask your GP to prescribe you loperamide syrup instead. So 2 medicine spoons of syrup are equivalent to the dose of 1 loperamide Imodium tablet. So it's very easy to use half a spoon or 1 spoon to adjust the dose of loperamide and then use that half an hour before a meal. And loperamide or Imodium have a life of about 6 to 8 hours in the body. So using it twice a day or 3 times a day is sometimes useful. So while 1 Imodium tablet might constipate too much, sometimes having half a medicine spoon of loperamide syrup 3 times a day, half an hour before breakfast, half an hour before lunch, and half an hour before your evening meal, can sometimes work really well as an alternative. So if you're struggling with LARS and you've seen a specialist and they've ruled out things like bacterial overgrowth, the pancreas isn't producing enough juice and you haven't got bile acid malabsorption, and they've tried you on a little bit of loperamide and you've switched that to liquid form and can't get that right, perhaps you've tried a bulking agent like Normacol and that doesn't suit you, possibly you've tried a stool softener like sodium docusate, and again that hasn't worked well, then there are 2 final options. One is to talk to your surgeon and say, should you actually have a stoma? Because by having a stoma, you won't be going to the lavatory all the time. And many people find that that's an easier long-term option. The alternative is to consider irrigation, which can be a very useful technique, though it is a bit time consuming. So irrigation is essentially washing out the bowel using fluid. And you do this at home. And there are a number of companies in the UK now who provide the service. So your GP can refer you for home irrigation. What it essentially involves is it involves putting a tube into the bottom end, putting some fluid into the bowel, washing the bowel out, letting the fluid come out into usually a closed bag, and then getting on with your life. And some people find that they have to do this every day, and it takes maybe an hour and a half to do it. Other people find that doing irrigation every second day or even occasionally every third day works for them. LARS is a difficult problem. Please ask your cancer treatment for help with it. And if you're not making progress, go back and talk to them and say that you're struggling with the treatments they've suggested. I'm really sorry. You are not alone. If you have a problem with bowel control, it has a huge impact on every aspect of your life. In some ways, having an accident with the bowel, if you have an accident with the bowel every day, it's possible to manage that. When you go out, you take 3 changes of clothing, you plot where every lavatory is, and you develop strategies about how you can deal with it. If your bowels are more erratic, then that is much more debilitating, because it becomes quite challenging to know how you're going to manage on a day-to-day basis and whether today's going to be a good day or a bad day. Having cancer in itself is quite psychologically traumatic. Often the diagnosis has been made quite quickly. You've had quite complicated operations and treatments, and you might not have had very long to think about the different options that you need to have. So it is very normal to be significantly challenged psychologically by what has been going on. It is very important to ask for help. It's very important to ask for help for two things. One, for your physical symptoms, and secondly, for your psychological symptoms. In my practice, when I was in London, and we had very good access to psychological support, 10% of all the people I saw in my clinic, I offered psychological support to. And every patient who went to see the psychologist, of the thousands I will have sent, I can't remember a single person who ever said it was a waste of time. It is normal to have very complicated emotions after coming out of treatment, and then when you're struggling to control your symptoms, those emotions often get out of hand. Please talk to people about it. Please go and seek help from your GP and from your cancer specialist team, and explain to them that you're struggling not only with your physical issues, but also with the psychological issues. And they need to be addressed in parallel. Both things need to be addressed together, and both teams need to talk. And often the interventions which are useful to help you cope with what is going on will also help improve your physical symptoms.